Okay, feel free to start it, Tiff, if you have that option. I don't see that option for me anymore. Hello and welcome. I see some familiar names that are popping in. Thanks everyone for joining us. We are going to give it just a moment to officially start. So as we all get comfortable in the virtual room, feel free to introduce yourselves in the chat. It's always a nice way to get a quick snapshot of who's joining us today. We have a full panel of a lot of great experts on this topic, so we won't have time to do a more in-depth audience engagement. So your introductions in the chat are really welcomed and valued. Thanks, Tiff, for kicking us off. Yes, before we officially start, just noting all the slides, all of the recording links, all materials will be sent to folks, anyone who registered after the session wraps before the end of the week. All right, as we still have folks coming in, we will go ahead and get started for the sake of time. So hello and welcome to this webinar focused on securing a strong connection. Oh, can we go back to the title slide? Thank you so much. Securing a strong connection to high quality telehealth for older adults. My name is Ariel Mather, and I'm the Senior Program Manager of the National Center for Equitable Care for Elders. We're featuring a lot of great work today from the Center of Excellence for Telehealth and Aging. So we will introduce our panel very shortly. But before we do that, we can go to the next slide. And as folks are familiar with already via Zoom, we have everyone muted to prevent background noise, but that doesn't mean we don't want to hear from you. Please do keep utilizing the chat to introduce yourselves. Thanks to those who are already doing that. We also have the Q&A feature since this is a webinar, and as our panelists are sharing information and their insights, feel free to put your thoughts and questions in there, either place for them. We will have a little bit of time held at the end for a Q&A, but when possible, some of our panelists will also be able to type some responses to questions as we go. As I mentioned a moment ago, all materials will be made available to all registrants before the end of the week. And as always, we'd love to hear from you. There'll be a brief survey that pops up at the end of this session when you close the Zoom. If you can take a moment to give us your thoughts on the session, that will help us improve our future training and technical assistance activities. All right, if you are not familiar with NCECE, very briefly, our goal is to provide health centers, primary care associations, other folks who are working in aging services, the resources they need to improve the quality of care for community dwelling older adults. There's a lot of links on the slide. Thanks, Tiff, for putting in our website in the chat. We hope that you'll stay connected with us. We have couple of newer social media channels that you can feel free to check out. We do lots of promotion of upcoming learning opportunities, as well as distribute things like our monthly e-newsletter. Some of those learning opportunities include, we have a couple of promo slides. The first being, in a couple of weeks, we're going to have a session focused on improving the recognition of early signs and symptoms of Alzheimer's disease and related dementias through effective communication with family caregivers, also known as informal caregivers. We have two fantastic, knowledgeable panelists who will be leading this conversation. If you want more information, Tiff can put a link in the chat. Thanks so much for that. We hope to see you there. We also have a learning collaborative coming up, which is a smaller group intentionally across several sessions. In this case, we'll have 4 sessions focused on exploring the role of health centers and meeting the complex and evolving needs of community dwelling older adults. Our fantastic facilitator will be walking us through innovative approaches to age-friendly care delivery and cross-sector partnerships that can effectively support this growing population. So thanks, Tiff, again for the links in the chat. We hope that you'll stay up to date with future learning opportunities and really value your participation in today's session. Great, so as you signed up for this session, you likely saw the learning objectives. We're hoping you're able to walk away from this session today recognizing really the growth and the significance of age-inclusive telehealth. We've come a long way, even in the last few years, and wanting to make sure we understand how it can align with the needs, values, and preferences of older adults and their informal caregivers. We're going to make sure you can walk away with a couple of core principles for telehealth for older adults and also have a lot more access to resources going forward to explore this topic further and consider ways that you can improve your own programs or approaches in this area. So without further ado, we have a really full, really talented panel with us today. They all have some brief presentations where they'll cover various aspects of this topic, and I'm going to let them all go one after the other. So I am going to do as quick as I can some bios because all of these folks have really fantastic expertise, and we're so honored for them to share with this audience today. So before we switch it over to our panel, I will quickly read these bios. We are joined today by Kathy Wibberley, who's been the director of the Mid-Atlantic Telehealth Resource Center since 2012. She has more than 30-year public service career with experience in public health, public policy, program development, program evaluation, grant writing, grants management, and strategic planning. Prior to this position, she was also the director of the State Office of Rural Health and Primary Care within the Virginia Department of Health. Maya Mendez serves as the telehealth program manager at the West Health Institute, driving an initiative aimed at enhancing the delivery of age-inclusive telehealth for older adults. With a background in social services, public health, and healthcare administration, she has spent the last 10 years dedicated to delivering patient-centered care and leading capacity-building efforts for healthcare facilities. We'll also be joined by Dr. Archibald Pannoni, who serves as the Claude Moore Associate Professor of Geriatrics and Infectious Diseases at the University of Virginia School of Medicine. She has over 15 years of clinical and research expertise with multiple grants and publications focused on geriatric clinical care and infection control. She's the medical director of Virginia Impact, optimizing technology for improving patient outcomes in congregate care and vulnerable communities. We are also joined by Anthony Nappi, who is a longtime advocate for patients and frontline healthcare staff, who's trained as a physical therapist and registered nurse and has worked at just about every level of care during his career. After years as a clinician, he transitioned to a nurse liaison role with the University of Virginia School of Medicine. His team, Virginia Impact, is focused on improving care access, coordination, and equity through telehealth optimization in congregate settings across Virginia. So again, we are so honored to have this full panel, really excited for the direction of this conversation. Please do put your questions and comments in the chat as we go along. So I will turn it over to you, Kathy.
Great, and thank you. So good morning or afternoon, depending on where you're tuning in from. And we are going to do a really quick whirlwind tour of how we got to this point where we're even thinking about telehealth and older adults. So next slide. Believe it or not, for most of you probably who participated and started telehealth during the pandemic, telehealth actually started over 40 years ago. And the focus of telehealth at that point was to solve rural health challenges. So it was really trying to deal with the workforce issue, the transportation, the geography, the weather, all of those issues. So next slide. So from that point, there was just a very slow evolution. It was mostly mission driven. And the mission was, let's fix some of those gaps in rural healthcare. And so in the late 70s and early 80s, for those of you who were around back then, we saw what was called the hub and spoke model, and it was to address the rural need. What does that mean? It means that a hub would be typically a large academic medical center in an urban area, and it would connect to spoke sites that were typically small rural hospitals. And this went on for a while. And then starting about the early 90s and into the mid 2000s, we started to transition to what I call a network of networks. And it was driven by healthcare reform. So for those of you who are around then, you really had this whole concept of personal responsibility, and people need to take responsibility for their health, and we need to do more health education and nutrition education, and we really need to help people understand their data and how much that impacts what they do. And so we started to have then these hubs and spokes starting to connect to each other. So we started to realize that, patients don't just go to hospitals, but they also go to community clinics. And so let's connect those community clinics to each other and to other hospitals. And we don't want to have a monopoly from one hub. So let's start to connect different hubs together so that, let's say I'm a small FQHC in rural Virginia, and I want to connect to several academic medical centers because one is really good at, let's say geriatrics, but another is really good at stroke care and neurology. And so I want to be able to connect to those. So we started to see this network of networks develop. So next slide. Starting in about the early 90s and into the mid 2000s, what we saw was a new vision taking shape, and it was the direct to consumer. Some people like to call it an evolution, but it was mostly profit driven. It was driven by for profit entities for the most part, really trying to make a dollar. They started to realize that, hey, this telehealth thing has legs. It's not just a pipe dream, and people can do this from their home. And so we started to seeing what I call a fully distributed network. So basically, you can get care anywhere you are, whether it's in your home, in your school, wherever. The vision was taking shape, but most people were not participating in this. We had, some insurance companies were kind of buying shares into companies that do this and offering this to their membership, but take up was really slow. So next slide. So I would say up until the pandemic, it was basically telehealth was slow and steady wins the race. There were all sorts of policies that were not conducive to mass use of telehealth. So most of the for-profit entities were, pay as you go. So you can pay one fee out of pocket, put in your credit card, you can get your acute care visit from your home, or your insurance company kind of sponsors it. So therefore you get that visit free, but the insurer is paying. So next slide. So here we are today. We had the pandemic. COVID-19 was basically what drove telehealth. It changed all of the rules and regulations and policies that were hindering telehealth growth. Telehealth exploded, and people started using it. And so next slide gets us to where the challenges are. When telehealth exploded and it became kind of synonymous with healthcare, particularly during the pandemic, and I know that many have returned to in-person visits, but the vast majority have continued with telehealth through a hybrid model. But when the worlds collide, we basically have the Flintstones and the Jetsons. We have older practices who are using older technologies with patients who have not learned the technologies. We have the digital divide from people who are not literate in terms of digital literacy, people who don't even have broadband yet, and that continues to be a challenge. And certain segments of the population where telehealth for the most part, those technologies were developed in Silicon Valley by 20, 30-year-old. They're not thinking about people with disabilities. They're not thinking about older adults. They're not thinking about, how the challenges of people with limited English proficiency. They're really just developing technology and they hope that it works well and they think it works well for their generation. So when that pandemic hit, and telehealth exploded, we really got to a point where we were like, there are certain populations that are just not accessing telehealth, not because they don't want to, but because they are just not able to at this point. And so this was part of why we started focusing on telehealth in older adults. And I also started working with people on telehealth and disabilities because we didn't want to create another layer of inequity in terms of who accesses healthcare. And so when these worlds collided, we really started to think and work on, what are best practices that would make sure that these equity challenges that we're facing during the pandemic don't last beyond the pandemic. And so from here, I will punt to Lori, or sorry, to Maya.
Thank you, Kathy. That was a great overview. Next slide, please. So I'll just start by providing a brief background on West Health. And I'm sorry, next slide. And we're a family of nonprofit, nonpartisan organizations entirely funded by philanthropists Gary and Mary West. And our mission is to lower healthcare costs to support successful aging for older adults through research, policy, advocacy, and philanthropy. Our work is grounded in real world experiences and reinforced by data driven policies and healthcare delivery models. And we really want to ensure that our initiatives have meaningful and scalable impact. Next slide, please. So as Kathy mentioned, in 2020, we saw a surge in telehealth adoption, but really despite this rapid growth, we saw significant gaps remained. So while more people turned to telehealth, older adults continued to face persistent challenges in quality, connection, and accessibility. And these barriers really limited their ability to fully benefit from these services. So one major issue was the lack of expert guidance and tailored solutions. And at the time, no organized body of experts or clear best practices existed, really to ensure that telehealth was implemented safely and effectively for older adults. So recognizing these barriers, we decided to take action to develop telehealth best practices for older adults and to ensure that telehealth remains a viable and effective option beyond the pandemic. Next slide, please. And in 2021, West Health Institute partnered with UVA and Matrix with Kathy and Lori to bring together experts from geriatrics, telehealth, hospital administration, and aging advocacy to tackle challenges of delivering telehealth services to older adults. And with this group of experts, we established the Collaborative for Telehealth and Aging, which developed a comprehensive set of provider-focused principles and guidelines to support age-inclusive telehealth implementation and design. And building on this foundation in 2023, we launched the Center of Excellence for Telehealth and Aging in partnership with Matrix and UVA to provide free practical tools and vetted resources that help providers and organizations implement age-inclusive telehealth. Next slide, please. And so this is our list of collaborative members. There are over 40 members representing academic medical centers, post-acute and long-term care facilities, aging advocacy groups, and philanthropic organizations. Next slide, please. So the collaborative created 3 principles and 18 guidelines, and they used a modified Delphi method and published a paper detailing this process. Each principle presents guidelines that providers can use in different settings, allowing for flexibility in their implementation based on the available resources in each setting. Next slide, please. So principle 1, the framework really emphasizes that telehealth care should be person-centered, ensuring that older adults' care's preferences, goals, abilities, support system, and conditions are fully considered. And I wanted to share some examples of how these principles have been applied in care delivery. And one example of this principle in action comes from a collaborative member who shared a case study on the VA's Video Connect Match pilot. And they're using a tool to assess veterans' abilities, needs, and tech experience to ensure that they receive the most appropriate telehealth services and aligning care with their individual circumstances. Next slide, please. And so the second principle focuses on equitable and accessible care, really ensuring that everyone has access to high quality care. And a case study from another collaborative member highlights this principle through the Geisinger at Home program, which was designed to expand access to care, reduce unnecessary emergency room and hospital visits, and support healthier living for older adults with chronic and acute conditions. By using telehealth and a physician extender care model that deployed community health assistants, the program doubled physician reach for older adults that were homebound and living in rural areas. And really overall, the program achieved lower ED visits, high patient satisfaction, and cost savings for the Geisinger Health Plan. Next slide, please. And the third principle emphasizes that telehealth care should be integrated and coordinated, ensuring that patients, caregivers, and providers work together across the care continuum. And another collaborative member shared insights on the medically home model, which reflects this principle through an integrated care model. So by combining virtual and in-person care with operational support, their program expands access to safe, high-quality acute care in the home. Medically Home's technology includes EHR integration to help streamline coordination among care teams, patients, and in-home service providers to enhance efficiency and seamless care delivery. And this model has resulted in high patient satisfaction, reduced inpatient admissions, and is a cost-effective approach to deliver acute care through telehealth. Next slide, please. And all of the case studies I mentioned can be found on the Center of Excellence for Telehealth and Aging website, which serves as a hub for age-inclusive telehealth resources. Our collaborative members have co-developed tools to help providers and organizations implement the principles and guidelines, along with additional case studies showcasing how age-inclusive telehealth is being delivered in various settings. And we also offer implementation guides and toolkits that really provide in-depth information and practical tools, such as screeners and assessments that can be used in practice. We also have implementation strategies that offer multiple examples for applying each guideline. And we have a resource library of over 100 external resources, ranging from research articles to webinars and podcasts. And the link to our website will be included on the slide. And next slide, please. And lastly, in addition to the resources on our site, we've developed 5 CME accredited online courses for healthcare providers. And we'll be offering a comprehensive training on implementing age-inclusive telehealth across various clinical settings. And so this course series includes a 60-minute introductory course on the principles and guidelines, a 60-minute telebehavioral health course, and 3 30-minute courses on person-centered care, equitable and accessible care, and integrated and coordinated care. And several of our collaborative members, including Lori, contributed their expert insights through video interviews featured in each course. Each course also includes supplemental materials such as 5-minute interactive microlearning lessons and companion guides to support the learning. And so we're currently partnering with the American Medical Association and the American Heart Association to host these courses on their educational platforms. So once the courses have been launched, we'll be sure to share the links with Ariel so they can share with you as well. And I'll hand it over to Lori.
Thank you so much. I'm Lori Archibald Pannoni. I'm a geriatric physician here at the University of Virginia School of Medicine. Next slide. Here are our disclosures, both for myself and for Anthony Nappy, who will be joining us shortly. Next slide. And so what I'd like to share is how we have evolved from the principles and guidelines working with the collaborative, with West Health and with Matrix to develop, to implement telehealth, age-inclusive telehealth practices in our local rural communities. So coming out of kind of the depths of the public health emergency, we were fortunate enough to receive funding from our state health department through federal funds to start Virginia Impact, which at the time focused on infection mitigation, prevention, and control through technology. And thinking about congregate care settings, how could we prepare for the next pandemic? How could we mobilize better lessons learned? What could we do differently if we were to face this again? Through that project, we brought together a community of practice of clinicians, administrators, staff members in long-term care facilities across Virginia, and really worked through over a 12-month period of educational sessions as well as listening sessions and trying to understand where we've been in use of technology in long-term care and then where we could go. And with that, we evolved the IMPACT program to focus more broadly than infection control, but to focus on improving patient access and coordination through technology. And that's where our focus is today. And we'll tell you a little bit more about that. Next slide, please. So through our community of practice that we gathered through our initial group, we put forth a telehealth survey, and this was a survey of practitioners statewide to talk about the anticipated and the experienced benefits and barriers of telehealth in long-term care facilities. And what we found from that survey is, you can see here on the right to start, Before COVID, as Kathy kind of explained, there was some use of telehealth in our congregate care communities. About a third had used some type of telehealth at some point. During the public health emergency, especially those very early days, we needed to get care to our patients. And so when we couldn't be physically together, telehealth was our option. And so during that public health pandemic, use among these providers went up to almost 80%. Following the public health emergency, there was some drop off in kind of the use of telehealth, but it was still much higher than it was before, because what we started to see was that telehealth could be a very helpful tool in the care of our patients sometimes, when used in a way that made sense for us, made sense for our patients, made sense in the workflow. It could be a helpful tool. And so we wanted to see, how can we make this something that could be implemented throughout congregate care facilities across Virginia. So in that survey, looking at what barriers were experienced when congregate care facilities were using telehealth, the three top barriers that came up was that the technology was just too complex. There was a lack of operational workflow, and there was difficulty with connectivity. Connectivity, as Kathy mentioned early, is a huge issue that needs to be addressed on a systematic scale. It's not something necessarily that an individual facility could change, but in terms of how do we use telehealth within our own workflow, that's something that we wanted to tackle with individual facilities, as well as the technology being too complex. The technology at this point can do pretty much almost anything. We just need to understand how our patients need to use the technology, how we need to use that in their care, and then how we can adapt the technology to be age inclusive and be most useful for our patients. So in our Virginia Impact project, we're focusing on the lack of operational workflow to help facilities kind of develop a workflow that works for them at each facility, and then to simplify the technology and the interface as well. So we'll talk a little more about that. Next slide, please. So working in direct collaboration with individual facilities, we've worked with facilities who want to grow their telehealth program in some way. We are always there to be driven by the goals of the facility and to help them get where they want to be. With that, we established the framework of how to think about optimizing telehealth for their facility. And with that, we developed this tiered approach with multiple meetings through administrative, clinical, on-site evaluations, and really starting to understand the organization and the flow, and then try to highlight to them how they can optimize telehealth with their program, and then work with them to do that. So the 4 steps in this framework, you can see here on this slide, I won't go through in detail, but they start with initiate. The first is to start somewhere. What tools do we have already in place? What infrastructure do we already have that we could leverage to develop how to optimize our telehealth program? Once we build upon that, we can start to integrate that. How can we integrate telehealth into our daily workflow, into the care of our patients? It's already existing, not to be some new non-integrated form, but to be coordinated according to the principles and guidelines, to be coordinated within their care and integrated within the workflow. Then, once we're integrated and we're using it, how do we make this useful? How do we incentivize use? How can we ensure that this is a tool that are helping our patients, are helping our clinicians, are helping our healthcare to be accessible? And then once we've developed that, to work to inspire. How can we share these practices, lessons learned with other facilities, and further grow the knowledge around implementing telehealth in congregate care facilities? So next slide. With that, we wanted to talk about a specific collaboration that we've developed with community-based partners in Southwest Virginia. So in 2024, I think it was early 2024, maybe it was late 2023, the Healthy Appalachian Institute at the University of Virginia College of Wise published the Blueprint for Health Improvement and Health-Enabled Prosperity in Virginia. So this was a document to document health outcomes in Southwest Virginia, as well as areas of need to target. What we saw from that survey is that access to healthcare was one of the greatest issues facing the communities and the populations. And so one thing we could perhaps try to help was, how can we use telehealth in a very vulnerable community to improve their access to care? So with that, I'll turn it over to Anthony, who could talk in more detail about what we've been implementing.
Great, thank you. So I'm going to approach things, just kind of put into context what we've talked about so far today, and discuss our partnership with the Mountain Empire Older Citizens PACE program, and kind of take a facility level or a ground level approach. So Mr. Smitty, this is a case example. He's a frail, medically complicated elder. He is a PACE participant at the Program of All-Inclusive Care for the Elderly, lives in highly rural central Appalachia, and has had some recent run-ins with the emergency department, and frequently calls the on-call nurse. So when the PACE center is closed, in this case, with this particular PACE center, a lone registered nurse is on call to field issues and calls from the entire census of participants. And they have about 100 participants total at any given time. So kind of the normal flow of the on-call process would be Mr. Smitty would have an issue. He'd pick up the phone. He'd call the on-call nurse using his flip phone. The pre-programmed on-call, PACE on-call nurse number is on his flip phone. And that, by the way, is the extent of his digital experience. So that's about the top of what he can do with respect to technology. So he would have a conversation with the on-call nurse, and essentially the nurse would do an assessment, a kind of a situational / clinical assessment based on that traditional phone call. And so the telehealth use case that we'll present right now, which was actually advanced by the PACE organization, is such that, what if that traditional phone call, Mr. Smitty calls the on-call nurse on the cell phone, what if that were pivoted to or transitioned to a telenursing encounter? And in that case, what would happen would be the on-call nurse, while on the traditional phone call with Mr. Smitty, would talk Mr. Smitty through going to the tablet that's been set up in his home, activating the screen of the tablet, pressing a single icon on the tablet that's kind of stripped down to just show a single icon, and then entering a pre-established virtual conference room to enter into a telenursing encounter. Once audio and visual are confirmed, they can hang up the traditional phone and proceed with the telenursing encounter. And so the thought on the part of the PACE organization and our team was, perhaps the nurse could complete a better assessment, get a bit more complete information from Mr. Smitty during that telenursing encounter, and a better decision would result from that improved assessment, and better outcomes would follow. So this is a telehealth use case that is being deployed over the next week or two. So I'm speaking of it just as currently as we can. So we've not hit, it's not gone live quite yet. So essentially, our job as consultants and partners with Mountain Empire Older Citizens really is, what do we do to maximize the likelihood of successful technology assimilation, specifically this use case. And our hopes are that one, it yields short-term benefits, so a better outcome, as I mentioned, that would be derived from an improved assessment during the telenursing encounter. And then also that this technology, the assimilation of this technology, would provide a foundation for kind of future expansion to additional use cases and future expansion across the organization. So that's kind of the setting that we have set there at the Mountain Empire Older Citizens. So we can go to the next slide. And so essentially, when I consider, my approach as the nurse liaison, I try to think of each side of the telehealth encounter. So I try to think of organizationally on the clinical side or the clinician side. And then I also try to break it down into the participant side of the encounter. So with respect to the PACE side and the clinicians and just generally the organization, we try to think of taking small steps, achievable, not overwhelming kind of an approach. And the framework that Dr. Pannone talked about, I envision that as kind of an organization-wide small step approach. It's tiered, they're achievable. It's not something that everything has to be done at once to implement the program, but I consider that more of the small steps in the context of the wider organization. We also think that it's important to take small steps in the design and scope of the initial trial. So I mentioned that the PACE census is about 100 at this point in time. In partnership with the PACE organization, for the initial telehealth trial, they identified 2 participants to begin this telehealth use case. So it's not, if they jumped in with 15 or 20 or 30 participants, that seems like that would be an overwhelming workload, and it would be something that would be tough to tackle. But they've identified 2 participants for the initial trial. Further, with respect to the design of the trial and the use case itself, these are not billable encounters. This is within the PACE organization. It's essentially a form of improved communication through telenursing. And these are also just sheer visualization encounters, so that they don't involve kind of Bluetooth peripheral vital sign devices or scales at this juncture. I think, again, the foundation will be laid for adding that down the road. But at this point, the focus is on small steps, early successes. With respect to data driving our interventions, we think about data driving the initial trial. So when we go back to Mr. Smitty, he had 8 emergency department visits over the past 6 months. He calls the on-call nurse maybe, let's just say 12 times every Saturday and every Sunday. So those are kind of data points that help identify a good candidate for improved communication through telenursing, among other data points that would be used, but those as an example. We also want to consider data to inform and drive program assessment. So, the data points that I mentioned about Mr. Smitty provide kind of a pre-telehealth baseline. But after the launch of telehealth, we want to look at things like qualitative data. So we have clinician and participant questionnaires to assess perceptions, satisfaction with the on-call processes since the telehealth launch, kind of get a sense of feelings about the use of the telenursing encounter, but then also objectively look at some of those same baseline metrics: emergency department utilization, number of calls to the on-call nurse, perhaps number of unplanned nursing visits during on-call hours, welfare checks. So essentially practice relevant metrics to help inform program assessment. Dr. Pannone mentioned barriers to telehealth adoption. And when I think of the organizational side, the operational workflow is certainly was at the top of the list in that survey. And also you see that in the literature and in our kind of site visits and conversations with other congregate care communities. That's often cited. So I think the framework, in addition to a small step approach, it provides an organizational kind of workflow for program program implementation. Beyond that, though, we think it's important to address kind of the nitty-gritty or day-to-day operational workflow. So this partnership with PACE has involved several, I think 4 so far, 4 site visits. During a couple of those site visits, we engaged with clinicians who will actually be using the technology, and we did mock encounters. And so our team was on one side, our team was on the participant side. In fact, one of the folks on our team is actually Mr. Smitty as a mock participant. And we went through mock encounters with the clinicians. We had a good time with it, and we all felt more comfortable with the process. And then we talk about post launch support with respect to kind of mitigation of that workflow or optimization of that operational workflow surrounding telenursing or telehealth. And so as they're launching this telehealth use within the next week or so, we have a standing meeting on Thursday mornings that I'm calling kind of open office hours for the organization. They can give me a ring and let me know that they want to pop in and work through something, knowing that there'll be glitches, and we can see, what we can do to optimize things as far as that goes. When I consider the participant side of the encounter, as Dr. Pannone mentioned, technology being too complex, although I think that can be on both sides of the encounter, it's in this setting, the participant is really the focus with respect to that barrier, that cited barrier. And so as I briefly described with respect to the actual encounter, the nurse on the cell phone rules out any dire emergency in the first 30 seconds of the phone call, but then literally talks the participant through walking over to the device that's already been set up in their home, activating the screen, hitting the single icon, which then brings them into a kind of a pre-conference waiting room. And then there's one additional icon they need to hit, which is a join button. So when I compare that to my last telehealth visit, where I received on my cell phone a verification code and didn't get to my laptop in time to hit it before it expired, Mr. Smitty's not doing any of that business. So we needed to really streamline the telehealth interface to work for him. And beyond that, considering the population of the care recipients you're working with, optimal physical setup, given the context of functional, cognitive impairment, frailty, that's important. We wouldn't want, we want it to be in a place that's accessible, it's reliably charged, doesn't introduce an extension cord to add to the already long list of fall risk factors in the home. So optimal setup of the equipment, training. So we work with the administrators and the clinicians at the PACE Center. We also work with the IT department. There's two guys who work in the IT department. They have done mock encounters with the two participants in the trial. So again, working through the same thing that we work through with the clinicians, but on the participant side. I'll just mention connectivity, just since that's an often cited barrier. And as Dr. Pannone mentioned, we don't have a whole lot of influence on actual connectivity. Our view essentially is we feel fortunate that there are initiatives and there is current funding actively in the region of Central Appalachia that is focused on provision of low Earth orbit broadband connectivity. And so our viewpoint is not that we can advance it so much, but we need to strike while the iron's hot. I mean, it's actually coming in meaningfully. Connectivity is really changing in a meaningful way at this point in time. So we really want to advance our initiative and take advantage of that, essentially. And then finally, the trust in technology, I would say that's on both sides of the telehealth encounter. And sometimes I approach, and this is kind of things that I've learned along the way. Sometimes I approach things and maybe it's a bit too of a business-like manner. And I think if you look at that, the often cited barrier that technology is too complex, if you were really to parse that out and look into that, I think there's an emotional component associated with it. I think there's discomfort and maybe even a bit of fear of new technology. And I found it refreshing during our last site visit. We met with some elders who served a double role as day center managers. This was within the wider organization, not necessarily PACE. But we met with them and kind of went through in a way and talked about, I didn't specifically point to here's our framework, but we pointed out your organization, the leaders in your organization have developed a telehealth team. Your IT department is committed, and we're committed to supporting you after as this technology is implemented, and essentially building a solid rapport in face-to-face meetings, telling stories, and really trying to nurture that trust in technology, because it is scary, and change like that is overwhelming, especially when you put that in the context of the generation of care recipients. And then you layer a very rural, underserved area on top of that. So that's kind of where we're coming from as far as our ground level approach. And we can go to the next slide. Briefly, where we go from here, the simplified telehealth interface that I just described, the deployment is pending anytime. We plan to expand to an additional use case within the PACE program. And then we also plan to help, the PACE program actually falls under Mountain Empire Older Citizens AAA. And we plan to work with them through telehealth deployment across some of their state mandated responsibilities. So group nutritional education and counseling, one-to-one counseling, and then fall prevention programs and cancer education. And so I think we can open this up to discussion and questions and go from there. So thank you.
Fantastic. Thank you so much. This was really informative. I'm so glad we were able to fit in so much good information in this time together. I want to give it a moment for folks to think about questions they might have, and we don't have any currently, but I have a couple. So I'd love to hear from all of our panelists. I think it's great to have so much context about implementation, and I love that that sort of chart that Lori and Anthony shared around potential goals and concrete action steps that folks can be considering, especially if this is not something you haven't implemented a robust telehealth program before. I think there's really great ideas there. I did want to talk, I think, a little bit more conceptually, I guess, about services and programs being age friendly. We talk about that a lot with our center. Generally, the age friendly health systems framework from IHI really focusing on what matters to older adults. So I'd love just additional insights from any and all of you around the ways in which telehealth can really prioritize what matters to the unique older patient, and then also kind of how that might translate to working with their informal caregivers, how we're thinking, I know that Anthony talked a little bit about trust in technology. I think that there's probably some layers too of perception, maybe on the clinician side of, is this older adult, will they be, able to interact in this way? Maybe some preconceived notions about older adults and their usage of technology. I'd love to just get thoughts in general about how we can be making our telehealth programming also, in line with our in-person programming, as age-friendly as possible, thinking about what really matters to those older patients. Anyone can jump in and start.
Go for it, Kathy. Okay, well, I'll go ahead and just start briefly and then turn over to Kathy. I think it's important to, think of the older adult as not one monolith, right? It's a full demographic generation with lots of variability, just like teenagers are a lot of different things, or children are a lot of different things. And so it's important not just to come in with some sort of preconceived notion of what is the older adult want to or not want to do. So really, it, like everything in medicine, goes back to that relationship of understanding the person that you're working with, understanding their goals, understanding their needs, and then trying to kind of go through your tool bag as to which tools would be best to facilitate their healthcare. Sometimes that's telehealth is one of those tools, and sometimes it's not. And when it's not, thinking through, well, what are the barriers? Is it there could be lots of reasons why it could be not, but are they some barriers that we could address? And Anthony talked about some of those we've been trying to address. But I think it comes down to really understanding the person that you're working with and then trying to identify, which tools would be most helpful.
I would piggyback on what Lori was saying. Not treating all older adults as the same is definitely really important. But also not having vocabulary, I think, is really important. And I'm just thinking about my own mother, who is 93. We just had to move her to memory care. So, but before that, how like explaining a concept like the internet and the cloud is like completely foreign to her. So how do we, take those words and those concepts and help them visualize that? I think is really important. Taking, concepts like, we struggled with having my mother operate a computer, but she could use an iPad like this. Like it took her about an hour to learn the iPad. It took her about 6 years to even turn on the computer. And then we would have a checklist of like every step to take, and she could not follow that. And so I think really, helping to figure out like not just writing them off and saying, oh, older people can't use technology, but like what's the right technology for them to use, and then how do you explain it in the right way? I think those are really important things to keep in mind.
And I would just add to what Kathy just mentioned, also bringing in the caregivers, especially if there are caregivers that live with the older adult, that can help with the connectivity, that can help with the technology, ensuring that, it's more seamless, and taking time, I think, prior to, especially a scheduled telehealth visit, to really train and kind of go over the logistics. Different health systems use different portals, different platforms. It can kind of be confusing if you're seeing one specialist in one health system and then another specialist with another health system. So I think really taking the time to go over the technology, how to use it, and also including the caregiver in that conversation as well, if the patient is comfortable with that, I think is really a good way to make use of creating an engaging environment as well.
Amazing. Anthony, any thoughts?
I would say we're fortunate enough to be working with a PACE program where just inherent in that level of care, the clinicians and the leaders within the organization tend to know the participants really well. Participants are typically enrolled in PACE for a long period of time. So they know the big picture, they know the caregiver situation, they know what the home setup is like. So, I think it lends to that kind of complete and individualized assessment of each participant to most effectively implement telehealth and get buy-in associated with that. But so I think we're fortunate with respect to just the characteristics of the PACE level of care.
Absolutely. I think that's a great point about PACE, especially. Not every program is as fortunate with a setup like that. We had someone, not really a question, but kind of a reflection. I think it's an important one, acknowledging there's really can vary technology comfort and use across older patients, but the concern that technology is always changing, it's advancing. There's things that those of us that have been well versed in technology for many years have to kind of figure out how to adapt to. The concern that the Anismer was sharing is around things potentially continuing to get more difficult. I know that, to Anthony's point, most recently, there are some setups like PACE where there really is a comprehensive team of folks that are ready to be addressing a variety of needs of older patients, kind of thinking about maybe a more general primary care setting. Do any of you have reflections on kind of the ways in which primary care staff can be supporting the learning process as things evolve? Certainly there's some, I think, legitimate concern about, well, what if something completely changes? Can you talk a little bit about there's a lot of priorities competing for a short amount of time, but any thoughts around how we best support folks as things continue to evolve technology-wise?
So there is a huge movement right now in the telehealth space related to digital navigators. And those are people who are specifically trained, and there are trainings available to help people, not just older adults, but anyone, navigate technology and increase their level of digital literacy. And those digital navigators can be hired as that, or they can be add-ons to a community health worker role or any number of roles that are currently exist in your practice or setting. And so having a person who really understands how to coach someone, how it's everything from how do I obtain an email address so that I can create an account so I can log into my, patient record, all the way to, how do I connect to the Wi-Fi in my home? I just got a new device. Do I need to download software? How do I do that? Um, older adults get this message frequently about safety and security and not giving out information and all of these warnings that they get. And then all of a sudden we're saying, oh, and by the way, log on to this account, give your personal email address, put in all your personal information and just go, just do it, trust us. There's a lot to navigate there from a trust space, from a understanding space, and from a technology navigation space. So having a trusted entity be able to walk you through that is really important.
I agree with that. And I also think about, so say if we're talking about a primary care center that's very much committed to telehealth, and it's not just kind of on the fly, but let's say they tailor their operations to perhaps a day that's committed for a certain practitioner to do telehealth appointments. And at that point, if they have a digital navigator or a telehealth facilitator who is available to deploy on the patient side of the encounter during the day. So the medical provider could be at the office or wherever, but the practice employs a digital navigator who can go to seniors' homes as needed and help on that side of the encounter. So I think, if a total commitment to the operation beyond just kind of on the fly telehealth, so that you could deploy that staff appropriately, I think is a good way to approach kind of overall workflow from that standpoint.
We've also had one practice that I worked with, just doing technical assistance with, that literally had the patient step into the next room and connect to a provider in the office when they were actually in the office, just as a test. Like, let's do a test here while you're in the office, and then when you're at home, let's try it again. And so I think that's a little small step to help them get comfortable with the technology, and you have someone hands-on right there with them.
Yeah, absolutely. We have just a couple moments. We've had several questions kind of fly in, so I want to be mindful of the time. I think there was a question probably that was related to the PACE program around how often patients were seeing folks face to face. In addition to telehealth, we'll have to table that a little bit, but I do think it's important to consider how often a patient is seeing a provider or a staff member face to face, what their relationship is like, the rapport. There's a lot of considerations there. There was a quick question around programming, grants, funding that can potentially connect older adults with technology if they don't have that and they're more homebound. I certainly understand that could be state dependent, region dependent. I certainly know of programs in our area in Massachusetts that have been able to set that up. But any final thoughts from our panel around what's a good place to go and check out what might be available in their area for their older patients?
I think a good resource would be, and I'll include the link in the chat, the National Digital Inclusion Alliance. They provide various resources across various states. And so that might be a good place to reach out to see what's available in your state. And the website is, I think it's digitalinclusion.org. So I'll include that in there.
Amazing. Thanks, Maya. That is all the time we have for today, but I really want to thank all of our wonderful panelists for their time and expertise. As mentioned at the, yes, we have a couple of resources, slides, links. You will all receive the slide deck before the end of the week. If you would like a certificate of attendance, we can absolutely give you that. Feel free to respond to any of the emails that you've received regarding your attendance of this session. We hope that you'll take a moment to give us feedback on this particular webinar and that you'll also join us for future learning opportunities. So thank you all so much for your time. Have a wonderful rest of your day. And thank you again to our fantastic panelists.
Thank you.
Thank you.
Take care, everyone.